Good afternoon. I'm Chris Cain, CPWR's Executive Director, and welcome to today's webinar on addressing COVID-19 health disparities. As many of you are aware, CPWR and NIOSH are holding these bi-monthly COVID-19 webinar series for the construction industry. You can access recordings from the whole series through a playlist on our YouTube channel. Jessica Bunting, our WebEx host for today, will share that link with everyone in a follow-up email. She's also online to handle any technical issues and assist as needed. If you're experiencing difficulties with WebEx or with your audio, just message her in the chat box or shoot her an email by responding to the WebEx registration or reminder emails. Should you lose audio at any point, please call in using your phone. The call-in information can be found in your WebEx emails or on the PowerPoint slide up on your screen right now. As I mentioned, Jessica is recording all the webinars in this series, including today's, and that will be sent to everyone along with a PDF of the slides and a follow-up email after the event. The construction industry has long experienced disparity when it comes to injuries, illnesses, and fatalities, with Hispanic and immigrant workers especially being at disproportionate risk. The current pandemic highlights these disparities, but also provides a unique opportunity to find ways to address them. We are all in this together, and keeping all of our employees, colleagues, and crews safe is a top priority for everyone right now. Today you'll hear from a number of panelists about the increased risk faced by minorities when it comes to COVID-19 and how this can be addressed through things like effective health and safety messaging. While CPWR staff is not presenting, I'd like to call your attention to a recent data bulletin we issued in May 2020. In that data bulletin, we identified underlying conditions in the construction industry workforce that put them at disproportionate risk for severe disease related to COVID-19. We have many older workers in our industry. We have more Hispanic workers in our industry compared to all other industries. And nearly 1 in 5 of our workers has a respiratory disease, and 1 in 4 has some other kind of underlying health issue that puts them at disproportionate risk to suffer severely from COVID-19. Overall, nearly 60% of construction labor force has at least one factor that gives them a higher risk of severe illness from COVID-19. I'd like to thank all of our panelists for taking time to join. Back to our data report, I'll put a link to it in the chat box for everyone, or actually Jessica already has. So that link is there, and please feel free to go review that report we put out in May. But I would like to thank all of our panelists for taking time to join. Today we're going to hear from Dr. Christina Socias-Morales, Research Epidemiologist with the Office of Construction Safety and Health at NIOSH, Michael Flynn, Public Health Advisor and Coordinator of Occupational Health Equity Program at NIOSH. He will present on models on how to reach populations that are at most risk from COVID-19. Dr. Anne Marie Dale is Professor at Washington University School of Medicine, and she'll share field examples of how the trades and minority contractors are handling COVID racial disparities. And finally, Carl Heinlein, Senior Safety Consultant with American Contractors Insurance Group, will describe how his team of contractors has been developing COVID-19 safety and health messaging in multiple languages to reach employees and their families. After our presentations, we'll have some time for questions and answers. We've received a number of advanced questions during registration, and we'll go through those first, followed by live questions as time allows. Please type in your questions at any time in the Q&A box. We may not have time to get through all the questions, but they're being saved and used to inform the topics and information shared in future COVID-19 webinars we host. Please also, in the question and answer, put ideas for information you want to know about COVID-19 and construction, and we'll try to address it in future webinars. With that, I'll hand it over to Dr. Socias-Morales to get us started. And thank you very much. Christina?
Thank you. Can you hear me?
Yeah.
Great. So thank you for that introduction. Good afternoon, everyone. I appreciate the opportunity to provide some brief updates for the NIOSH Office of Construction Safety and Health. So I'll be presenting some quick statistics on the construction workforce compared to the U.S. workforce by age, sex, race, and ethnicity. And this is just a taste of what you would find in the CPWR bulletin that Chris mentioned, so I encourage you guys to check that out. Then we're going to look at a little bit of data for COVID-19 hospitalizations overall in the U.S. by age, sex, race, and ethnicity. And finally, just I wanted to highlight a couple of recent MMWR articles related to COVID-19 that seem relevant to our discussion here today. So using data from the current population survey from the Bureau of Labor Statistics on our workforce by age. Oh, are people seeing the slides advance?
Yes.
Okay, great. So I have a graph here, and using the data from the current population survey by age, here's a picture of the construction industry in gray and all U.S. industries in black. And we can see it's sort of skewed towards the middle ages, 35 years to 54 years, with fewer younger workers and fewer of the workers at the top of the age ranges compared to the rest of the United States industries. And again, from the current population survey with construction in gray, we can see that there are substantially more men in construction, no surprise to anyone on this call probably, and there's a higher representation of white workers compared to Black or Asian workers, but there are many more Hispanic or Latino workers of any race in construction, almost double the proportion of Hispanic Latino workers in construction compared to the general population. So now looking separately at COVID-19 hospitalization rates across the country, there is a clear increase in hospitalization rates as age increases, and I think most of us have seen this information. And although it's not listed here, I did want to say that various sources have shown there's a slightly higher hospitalization rate and fatality rate for men compared to women. Another picture of hospitalization rates across the country, we can see that non-Hispanic American Indians or Alaska Natives, non-Hispanic Blacks, and Hispanic Latinos of all races have incredibly high hospitalization rates compared to non-Hispanic Asian or Pacific Islanders and non-Hispanic whites. So in fact, the hospitalization rate of Hispanic Latinos is 4.5 times that of non-Hispanic whites. So moving on to the MMWRs, a recent MMWR article describes the first state, Indiana, to conduct a random sample survey to try and estimate the prevalence of the SARS-CoV-2 infection, which means it's the viral infection regardless of whether you have symptoms or not. So the random sample was derived from tax returns of non-institutionalized Indiana residents aged 12 years and older. In the last week of April, the study participants went to one of 68 clinics around the state for both PCR tests for active viral infection and also the antibody test, which is a blood test for ever having had the infection. Hispanic survey participants, as you see here, had a 4 times higher prevalence of infection ever compared to all participants. This suggests the need for communication strategies tailored to the culture and languages of local communities, engaging local leaders, and when possible, allocating more testing and contact tracing resources, and also focusing on reducing workplace exposures to prevent additional infections in these groups. Another interesting result from this study was that 44% of the respondents who were positive for current infection of this were also reporting no symptoms at the time of the survey. All right, and so now we're starting to see a lot more information about the clinical course of COVID-19 and return to baseline health for persons with mild or outpatient illness, and even among younger adults without chronic conditions. This article describes lengthy recovery from COVID-19. Basically, they conducted a telephone survey and found that about 1 out of 3 respondents hadn't returned to their usual state of health for 2 to 3 weeks after testing. So that's not even counting when their symptom onset. That's actually the time that they were tested. For younger respondents, aged 18 years to 34 years, there's still about 1 out of 5 that hadn't fully recovered after 2 to 3 weeks. And for respondents aged 50 and older, that proportion goes out to about half. At this point, we really need to remain diligent and continue our social distancing efforts, hand washing and universal face covering in public areas. And even for workers who might be healthier than the general population, this illness has only been around for a few months, and we're still on a very steep learning curve. So just a couple of quick reminders. There are several resources related to COVID-19 and the construction industry, many of which have been described in previous webinars in this series. And also the bulletin that was posted in the chat box. I'd also like to remind everyone that the Construction NORA Sector Council has a COVID-19 working group that meets monthly to discuss current issues and to share resources. A special thanks to Mike Mills of Liberty Mutual and Travis Parsons of Laborers Health and Safety Fund for co-chairing the group. If you are interested, please reach out to me, or Scott, or Liz for more information. And that's all the updates I have for now. Thank you for your time, and I will turn it over to Mike.
Thank you all for inviting me here. I'm happy to present. What I'm going to do is talk a little bit, kind of root some of our response efforts in a larger picture, so that one, not only do we have some tools to effectively respond to the current pandemic, but that through this response with the right planning, we're also better situated to address future issues as well. Next slide. So currently, the current situation, what we're finding in the pandemic is it's raising or accelerating our understanding that there's a complex relationship between work and health, which is broader than traditionally has been understood or framed by occupational safety and health. A lot of this work you can see being done at NIOSH and across the occupational safety and health field under the Future of Work initiative, but the understanding that the impact of work on individual and community health is much larger than what happens from 9 to 5. I think the other significant social aspect of the pandemic is that it's really highlighting the social inequities that exist within society. And work is a significant contributor to these inequities and the inequitable distribution of health outcomes. What we're finding in this pandemic is that there's an overrepresentation of minority and low-wage workers, both in essential jobs, which requires them to go to work, interact with the public, and increases their exposure to COVID. And then on the other end of the scale, also many folks who are not in essential jobs, but minority and low-wage workers, often end up unemployed because they don't have the facility to telecommute like other workers do. Next, please. So when we talk about occupational health equity, basically what we're talking about is that the way society organizes, is organized along axes such as race, gender, ethnicity, nativity, the way industries are organized in terms of the subcontracting of risk from the primary contractor out to smaller businesses, and the way jobs are organized from, again, job arrangements from permanent to temporary and whatnot, all impact the distribution of positive and negative work-related health outcomes. And what the Occupational Health Equity Program here at NIOSH works on is trying to identify these structures that lead to avoidable differences in workplace disease, incident, and illness, right? and especially those that are tied particularly to social, economic, and environmental disadvantage, and then find ways to try and overcome them. So many of the disparities that were recently talked about with different groups with COVID, for example. Next slide. Yeah. And so why are we doing this now, right? Well, overall, the workforce is diversifying, and even in construction, we're seeing that as well. Increasingly along gender lines, the more and more people are moving to non-traditional occupations. So women entering construction, men entering nursing, et cetera. We're seeing a blurring of some of those gender lines that have traditionally segregated the population into types of workers going into different types of agencies, or industries, I'm sorry. Age as well, we're looking, as was referred to earlier, people are working later in life, which in the current situation puts them at an increased risk for negative outcomes during the pandemic, and also likely increases the number of underlying conditions they may have as well. Ethnic and racial diversity, we're seeing, the projections are that by 2042, there will be no ethnic or racial majority group in the United States. And as the previous slide showed us in the presentation, over 30% of the construction workforce is Latino. And then immigration, right, or nativity. It's estimated that in 2050, immigrants will represent, roughly a quarter of all working-aged adults. And in some industries, they'll be even more. And I think construction is one of those where you're seeing significant, is a long history and tradition of immigrants entering the workforce to the first generation through the construction industry. Next slide, please. Matt, can you put slides, please? Hello? Oh.
So I'm seeing them advance.
I got it. So how do we account for some of these differences in the diversification in the workforce? One, we need to know that, I'm going to go back to this one. They're different for each of these different groups. We have to respect the different perspectives that come with this. So right now I'm going to start focusing, much of my work is focused on Latino immigrants, and so I'm going to switch here and using them as an example, right? So when you look at what contributes to different perspectives of workers from different backgrounds. One, with Latino immigrants, for example, knowledge. They come in with a different knowledge. Construction in Latin America is done with different materials, under different regulations, with different assumptions. And so often workers who have worked in construction in the past come in with different expectations, different knowledge base, and different understanding of what's safe, what's unsafe, and how things are done, which may not necessarily jive with what's here. In addition, workers working in construction may not have worked construction back home. They may come from a different industry, farming, for example, and have now been integrated into construction here, which means they're also coming with a different baseline of assumptions and knowledge that's different from workers who were born in the U.S., right? Culture is another key aspect, right? When you talk about the workers' culture, we're talking about what are they bringing with them to the job. One example would be, how do they define or see risk, right? If you're, for example, an undocumented immigrant who just spent the past, risked so much crossing the desert, at risk of, being extorted or kidnapped or whatnot, and end up here, not wearing a hard hat you may not perceive that as risky as someone who hasn't gone through similar trying circumstances. And so different ways that, what workers bring with them either from their home country or their current living situation defines how they see risk, how they understand safety, what they put a priority on at the job, right? I think one thing that's also very important to remember is that institutions also have cultures. Oftentimes we just focus on the culture of the workers, but institutions, or the way we do things here, is also a cultural construct. For example, the open door policy, you'll talk to supervisors who say, well, I have an open door policy, any worker can come in and bring a concern to me. Well, oftentimes workers, because of language or previous experiences, let's say immigrant workers, are often not likely to take advantage of that open door policy. And you just can't sit back and say you have that. You have to actively go out and reach out to them and bring them in and build the trust with them, for example. So it's not only workers that have to assimilate to the conditions they find here, but it's also institutions that need to change how they do things to meet the needs of their workforce. And finally, structures. There are larger structures outside of the industry that impact the way workers see things. So, for example, immigrant workers, you know, a recent policy change came down where immigrant workers or immigrants who took advantage of means-tested benefits from the federal government, that could have a negative impact on adjusting their immigration status. And now, while USCIS has come out saying that, you know, access to COVID-related benefits is not going to negatively impact them, oftentimes that word doesn't get out into the immigrant community. And so they may be afraid to take advantages of free services that are out there, and it's something that may not occur to some of us who aren't immigrants, right? So the key thing here is that we can't assume a common understanding. So how do we move towards developing inclusive organizations? I think there are three key areas. One, you know, who's doing the work? Who do we have on site doing the work? What's our personnel situation, you know? Are we developing a bilingual, bicultural infrastructure that facilitates communication and building trust? And also at what levels? If the only Spanish speakers we have are, you know, the frontline workers and no one up the food chain, then that limits the communication channels and also the ability of the organization to respond to the needs of the workforce, right? When we look at practices, we also have to look at how we do things, right? As I was saying earlier, workers and institutions must adapt. So as was mentioned by the previous speaker, we need to tailor trainings and interventions to, you know, for the content and the format that the workers understand it best and is most effective with them. And like I was saying earlier, you know, an open door policy may not be enough. You actually have to reach out and overcome some of these barriers to pull these workers in and develop the trust with them so that they see the organization and can take advantage of the resources being offered, right? And finally, partnerships, or who are we doing this with? You know, oftentimes we hear these workers they're called hard to reach, but oftentimes their organizations of these workers say, well, it's not that we're hard to reach, it's just we're hardly reached, or you don't know how to reach us. So finding key organizations, there are all kinds of infrastructures within immigrant communities and other minority communities out there. And so it's plugging into those infrastructures and developing relationships with those groups will help reach while you're developing the internal institutional capacity to address these issues. This is a nice stopgap measure to overcome those, right? So moving forward, what do we need to do? One, I think it's essential, as you'll hear from many of the speakers today and other places, right, to address the immediate needs and challenges that this pandemic is presenting us with. But we also need to realize this is happening within a context of an increasingly diversifying workforce. So if we can meet the current needs to address the situation while trying to leave us better at the end of it for addressing the diversity in the workforce for future pandemics and other issues, or just routine increasing safety at work, it'll be very important. So we need to meet the immediate needs while developing institutional capacity and developing both a react to this current situation, but a proactive approach in how we're reacting to this builds our long-term capacity to better deal with these situations in the future, right? We need to identify and adapt to with existing partners, right? So once you find partners in these communities, we need to adapt our needs to what their programs are in a way of limiting the burden and increasing ROI. So to the degree that we can get them, you know, we can insert occupational safety and health or pandemic response into what they're currently doing, it makes it easier for them to institutionalize these adaptations and therefore makes them more sustainable, right? And then finally, build and maintain relationships. It's best to include partners in the planning and the funding of projects before they get started, while they're ongoing, in terms of an evaluation. And it's important that any one individual project should be seen as part of a much longer term relationship down the road that will help us adapt to the growing diversity within the workforce. And here I just want to point out two resources. These are hyperlinks. One, you can touch the NIOSH Occupational Health Equity website, which talks about these things more in general, and then also the CDC Pandemic Health Equity website just came on board, and that has more COVID-related specific information. And with that, thank you very much. There's my contact information, and I'll turn it over to the next speaker.
Thanks, Mike. And Emily, the floor is yours.
Thank you. Thanks, Mike. That was a great segue to what I'm about to present. So my name is Anne Marie Dale, and I am a professor at Washington University in St. Louis. And I've conducted research in the construction industry for over 20 years and have developed a lot of partnerships with contractors and construction organizations, both locally and nationally. And through those partnerships and relationships, I'd like to present for you some of the lessons learned that I think will help know how to address this issue of potential COVID transmission among minorities and this challenging work group. So I want to reiterate some of the points that the previous speaker made, which I thought was fabulous. So when we're dealing with minority workers and minority populations or ethnic populations, there's a tendency for all of us to want to work and be together with people who are like us, and that's no different in this group. And it is for that reason that oftentimes we see many people from the same minority employed in the same trade, even by the same employer, and certainly in the same location. And then these individuals will often work and travel and even live in close proximity with each other, which is a pro and a con, as I will soon show you. Racial and ethnic culture, as Mike so well presented, they tend to be very social with each other, and they are each other's support. And so therefore, these individuals are often there to support each other for child care and elder care and other needs. And so these individuals socialize with each other away from the workplace just as much as they do at the workplace. And in addition, many individuals are struggling with mental health issues, and that's certainly higher during the pandemic. Interestingly, I'm not sure that it is true that it is significantly higher among Hispanics in particular, but it's important to realize that it is the natural support of being together, working together, that creates that natural resilience that's so helpful for managing mental health issues. Now, Dr. Morales already presented information on the high prevalence of COVID cases among some minority groups, and that was well stated. We know that many minorities have higher rates of comorbidities, and the comorbidities are also contributing to the higher case counts that is seen in the minorities. Here in St. Louis, we do a lot of graphical work and have shown that in our region, and I think it's no different in other regions, there are cases that are higher in selected zip codes in our county, and this corresponds to individuals with lower income. And not surprisingly, this is in the same area where individuals live in close proximity within neighborhoods. And so there's a tendency for these individuals to congregate together, live together. They tend to be living among others who have lower income, and then they also tend to work together. So it is this natural culture of wanting to be together that we actually can leverage on for support in the workplace during these COVID times. So some of the contractors that I've been talking to have encouraged these groups, these minority groups in the trades, to actually form into natural groups, or what are sometimes called families. These individuals will live, travel, and oftentimes work together. They may be on the road together. Road crews would be an example. But it's really important, if this is something you want to encourage, because these individuals can benefit from working together, both financially and for mental health reasons, that you try to minimize the group size. Because if you have one of the individuals in that group becomes a case, then in fact all of those individuals are exposed. I just was on the phone with a contractor this morning, and they had a group that was just like this, and it was the group size was 19, and one of the individuals developed a case. So now you end up with the whole crew, and it's a large crew, ends up having to quarantine. So be cognizant of how many are going to have to quarantine if, in fact, one individual becomes symptomatic. It's also beneficial to let the workers choose their group, and that's based on their the logistics for work and travel and where they may live. And it also empowers them to work together, and it can be part of the buy-in that you working with the culture, or as Mike said, meet them where they are, to encourage better compliance. It's important to provide education and training on best practices, particularly related to pandemic practices. We need to educate on social distancing or physical distancing, as some say, the importance of face coverings and wearing them 100% of the time, and hand washing and sanitizing frequently while they're in each other's presence. But it's important that this training is provided in their own language, and in the signage is presented in their language, and it is presented in a way that's meaningful to them. As Mike emphasized, these individuals come from a different perspective, and they need to understand how important this is, and it needs to be said to them in a way that will be meaningful to them. It's also helpful if you get buy-in from a particular individual from the work group, who then can be the representative to encourage those healthy behaviors both at work and outside of work. If there's an individual that's trusted within the group, it might be beneficial to pull them out, educate them, particularly if that's an individual that the contractor can relate to, and encourage greater education on that individual, because that will be carried through both during on and off work. It's most important to get input from the workers, particularly on best practices and ideas to change the work activities to reduce risk. This is always a good idea. I think sometimes the language barrier presents a problem, but I think it's important to remember that these workers, oftentimes, if they understand what you're trying to achieve, they have the best ideas. Face covering compliance is particularly challenging for the construction industry at large, and it's no different in this group. I spoke to one contractor who has a large group of Hispanic employees, and he had his own kids make the masks or face coverings for the workers. And that was his way of showing his true concern for them as employees. I think, his thought was that the employees would be more willing to wear them because his children made them for him. Some of the workers may prefer to wear a different form, such as a neck gaiter that covered the mouth and nose. Working with the employees to find out what they would prefer, I think, is important. It also might be useful to ask if one of the workers has a family or friend among them who has skills to make masks, again, to get group buy-in. My daughter works with Africans, which is totally separate from this issue, but she actually has them make masks in the cultural fabrics, and that gives them more buy-in. Finally, it's important because we know face covering compliance is also associated with problems of wearing them from heat stress. It's important to work with, encourage hydration and breaks from heat, just like we would any other time. But most of all, realize that minority workers are no different than any other workers that we want to create strategies and best practices on the work site. So several of the contractors and organizations that I communicated with as I was preparing for this presentation said, I want to protect everyone, so I want to create policies that are useful and best for all, which I agree, and those should in fact benefit minority workers equally well. Some suggestions that some contractors have done is they've actually purchased more tools to eliminate the need for sharing, and therefore there's fewer in-person contacts and need for cleaning. Other contractors reported on using more mechanical means to transport loads, particularly for heavy loads that typically require 2 or more workers to lift and carry. And in doing so, you eliminate the need for social distancing because the workers can do it alone. It's also great to look at other practices that would allow one worker to perform the task rather than 2, if there's a way to develop a work practice that might be possible. And finally, I think it's important, and this came forth from my communication with one contractor, is to recommend that all employees consider their individual needs and risks and to act accordingly, to encourage, help educate the minorities as well as all workers that they may in fact have higher risk, and that it's important for them to protect themselves and take seriously social distancing and wearing masks because of their personal higher risk. Not to single any individual out, but just to acknowledge that this is true and to make sure they understand what is, why it's important to do that. It's important to help workers understand that the risks of exposure to COVID are no different from others at work, in the community, and at home. So helping them carry this message back home into their personal lives, going back to Mike's very first point, that it's hard to separate health issues when you are just speaking about work. It's important that these messages are carried home and into the home, and that workers are encouraged to be compliant in the home. So I will leave it at that, and we'll be happy to answer any questions that you may have.
Thank you, Anne-Marie. And next up, Carl, I will hand it over to you.
Well, good afternoon, everybody. Depending on where you're at around the country, we have a great audience today, but I'd like to first thank NIOSH and CPWR for, again, continually being thought leaders and being a trusted resource during these times. As we can probably all attest to, there's a lot of information out there, and trying to get to the information that is clear and critical for your teams is very important. So thanks to NIOSH and CPWR. I'd also like to thank my fellow presenters. A lot of good information already from the 3 previous presenters that really kind of feed into what I'm going to talk about today is, taking some of the research and kind of putting it into practice, what some of our contractors are doing each and every day. Just a little high-level overview of who I work for and why this is kind of important to us. COVID hit the West Coast, kind of the Washington area, back in February, if we can all kind of look back and take a look at the timeline of COVID. And I work for a captive insurance company, and we're owned by 40 contractors around the country, and we have a number of contractors that work in the Washington area. So we've been working in and around COVID really since day one. So we've learned a lot of lessons. We've continually reached out to folks. So one of the things that we've learned in this is really we kind of kick it around. We want to make sure that we're focusing on any disparities of our workforce, where English may be the second language, age may be an issue, race, authenticity, sexuality, all the different disparities we work with on construction sites. We see it each and every day around the country. So we want to make sure that we're providing clear and concise information. But the 5 C's that we've been kind of kicking around internally and with our contractors is clear, consistent communication via channels and collaboration. So I'll say that again, clear, consistent communications via channels and collaboration. One thing we found out when we started through this is we cannot do it alone. So working with folks like CPWR and NIOSH, working with our local union representatives and leaderships, working with associations like AGC of America, American Road and Transportation Builders. There's a lot of folks out there that are trying to share and provide information on what they've learned from their internal committees or their contractors themselves. So one of the things that we really took a look at, and based off of the conversations from our previous presenters, a lot of these have been taken and utilized in the forms of town hall meetings with our contractors on a regular basis. That covers a number of our employees, but does it get to the folks in the field? So toolbox talks, white papers, different addressing of our job hazard analysis, job safety analysis, but really having team meetings are some of the things that we're doing. And I'm going to show you a couple samples here in a second that our friends at the AGC of Washington, in collaboration with the AGC National and the AGC, the Oregon chapter, have been working on since February on working on providing clear information that they can take not only to the job site, and this is something that we found as well, it's important, and is in some cases our employees may be safer on the project than they are at home or in their vehicles. So our messaging has to be 24/7, 365. So we really started to take that theme on as well. We wanted to make sure that also that information was not only for the employee, but we were trying to help our messaging go back to their families. In many cases, some of our construction workers, hardworking folks, work in many multi-generational families. So they may have kids, parents, grandparents. So again, trying to get that message home to them in a clear and concise message was critical for us. The other thing too is what we did, and we received a lot of feedback on it. We provided a lot of information, but we never trust and verified that that information was being understood. We put it in a way or a method that was understandable. So a lot of actions sometimes weren't really resulting in the understanding and the knowledge that we wanted to. So we went back and rekeyed and learned a little bit, talked to the employees, learned from them, and created some different formats on how we were going to take this message to all levels of employees and their families. So, you know, one of the things that we learned right off the bat is a lot of people don't like to read a lot of words. So the use of graphics, pictograms, color codes, things of that nature to make it easy. One of our employees said, you know, when I travel, if I look at a train station or an airport, a lot of it is just pictograms, and I understand what to do. So we really took that to heart and really changed some of our messaging up on that. So, Jessica, if you could switch over to my first slide, I'd appreciate it. So I don't know how many people knew this or not, but July is National Minority Mental Health Awareness Month. I know that we're right at the end of July, but that doesn't inhibit us from taking some of the information that's on this slide that was created by our friends out in the AGC of Washington, the AGC National, the culture of care. And this information will be available for you. You can hit on that and utilize that any way you would like. But there's some excellent information, and there's some personal stories. There's some things that really resonate with the workforce. And the one thing about it is, as we go through this pandemic, we're hearing more and more and more about people that are having more issues with stress, mental fatigue, mental wellness issues. So we're really trying to implement a lot of mental check-ins as well. How's everyone doing? A little bit more of that check and verify everyone's okay on the team. Just like any sports team, before you start, a stretch and flex, coach is checking in on. We're trying to get this, and we're starting to see a lot more uptick from our frontline supervisors doing a better job on this. So, Still have work to do on it, but we're watching some improvement in that area of better, clearer, consistent communication. So this is something, hopefully people take a look at this, take it back to your teams. This is something, just because July's over, there's no reason why you can't take some of these resources and share those with your teams. The next resource, please, the next slide. So this is one I think that provides a lot of opportunity for folks to take back to your teams, adjust and put into your verbiage, your language, whatever works best for your team. But there is some excellent resources. Again, this is from our friends at AGC of Washington, and Mandy Cain and her team have been working with Dennis Barlow and Barb down at the AGC of Oregon, and then Kevin Cannon at the national office to develop these resources in HR. And I think this is a perfect point to talk some things that we've learned as well. In many cases, when this started, we watched people working in silos. Safety was doing one thing. Our fleet managers were doing another thing. HR was doing another thing. And then we started to figure we were kind of swimming upstream and not helping each other out. So the one thing we started to do was a lot more collaboration, building a COVID team that addressed a number of these issues. So when you take a look at this, when you see, oh, HR resources, that's not for me, that's for the HR department. I think that a lot of these resources right now are good for all leaders, safety, operations, HR. So as you could take a look, anti-harassment, discrimination videos. In some areas of the country, these are required. Some companies, they require this information. This is stuff that is easily accessible for you, easy to use. 20 best practices of HR on diversity. This is certainly something I encourage everyone to read. And then there's some sample policies. We can scoot up a little bit more. We've got a video clip in there. I encourage everyone to take a look at that. It's well done. It's something I think that every level of an organization will embrace when they read it and observe this video. Really well done. It hits on some very key points that will resonate with your employees, your managers, operations folks, folks in the office, as well as folks in the field. And then to the bottom here, the toolbox talks. I think this is always, we're always looking for something to take away from these calls. Here's a couple toolbox talks that I think that would work at all levels of the diversity and disparities within your organization. You know, how to speak up, mental wellness and workplace safety, featuring a culture, fostering a culture of care, respect, inclusion, and diversity, and then regard, respect, and resolve. These are all tools that everyone on the call today can take, adjust to your organizations, and put in place literally tomorrow. But one thing I want to say is the thing that we go back to is the clear, consistent communication via our channels and our collaboration. The one thing on these is make sure that our folks are truly understanding. We've heard that from a couple of other presenters today is we have a lot of information, but are we checking, are we trusting and verifying that this information is being understood? You know, and that's a real key. There's a lot of stuff out there. So again, as we go down through this slide, there's some toolbox talks. We are always big in trying to make things visual and stand out and celebrate. That's the thing that I want to kind of close on is really a couple things. Is I think that America progresses through construction, and I think there's an opportunity for us to celebrate the great things that we're doing in the pandemic situation and all the other things that are going on in the country right now. When we take a look at our hardworking construction folks, are we celebrating them? Are we thanking them? Are we celebrating what's going on? So kind of think of the positive spin on the kind of an unfortunate bad situation in many cases. How do we celebrate our workforce? Do not overlook the other hazards that are around us. COVID has absorbed us up every day, every hour that we're on projects. But we still cannot overlook the Focus 4, +1 ergonomics, and what other hazards you may deal with depending on the sector of the industry you're in. So are we keeping a close eye on falls and struck-bys, caught in between, electrocutions? This is an opportunity when we're slowing down for COVID to address those. Let's not overlook the hazards that we dealt with before COVID, and we're keeping an eye on it. We don't want these distractions to take our eye off the ball on that. And then last but not least, we have to continue to listen and learn. Talk to our employees, collaborate with our friends, colleagues, subcontractors, because we're not out of this yet, and we're continually learning. And opportunities like this, the webinars, provide a lot of great opportunity for dialogue, interaction, and I encourage everyone, if you have best practices or thoughts you heard earlier, please share them with the host, Jessica, and she'll get that out to everyone, and we're all going to continue to learn. So, again, thank you very much for the opportunity. I'm always available to share anything that I may have or our contractors have, but appreciate everyone on the phone. We need more folks like yourself to help improve our industry each and every day. Thank you.
All right, thanks, Carl, and thank you to all our speakers. This is Chris again, and we have some time for questions and answers, so I want to dive right in. I'm going to start with some questions that came in with the registrations, and starting with Christina. The question was, how are some of the trades and contractors dealing with the combined threat of COVID-19 and extreme heat, given that PPE can make workers more susceptible to high temperatures and abnormally hot conditions are expected this summer? They're here. Christina, can you respond to that question?
Absolutely, Chris. Can you hear me okay?
Yeah, you were a little muffled during your presentation, but I think you sound pretty good.
Okay, sorry about that. So basically it is a huge concern. Like you said, this summer is expected to be pretty hot. But OSHA does have guidance related to occupational heat hazards. And specifically, we want to encourage employers and workers to make sure that workers are consuming adequate fluids. They might be working shorter shifts to reduce their heat burden and taking frequent breaks. And then also educating workers on how to quickly identify any heat illness symptoms. So there's a lot of information about this, and NIOSH, the construction office, recently did a blog on heat stress, so I can post that link in the for us.
Great. We'll make sure to put that in the follow-up email as well. Thanks, Christina. The next one is for Mike. So this question is about asking if somebody can describe the magnitude, distribution, adverse impacts, and how to address the problem of vaccine hesitancy and inadequate health literacy, and the issue of misinformation and disinformation among minorities. Mike, can you address or kind of speak to that issue?
Yeah, I think it goes back to one of the central points of my presentation, is the need to do a better job of incorporating different organizations and structures within these communities into the public health infrastructure in general and the COVID response in particular. I think there are a lot of rumors and whatnot that go on out there, but until we can really truly integrate and work with, like I said, there are many organizations and infrastructures within these minority communities who often don't have a very extensive or significant relationship with their local, state, or federal public health institutions. And so I think the current COVID response gives us an opportunity to really reach out and try and build those relationships, not only to get word out about, the correct prevention mechanisms and just basic information on COVID, to integrate, trusted members of the communities out there and organizations in the communities, train them up on contact tracing and whatnot so that they can either facilitate or even conduct it themselves, integrate them in plans on how to develop vaccine distribution within the communities and get information out about that. And so I think not only is it important to integrate them into this immediate response, but if we take this long-term relationship approach to these partnerships, we can not only effectively respond to the immediate needs, public health needs we're facing currently, but have them be further integrated into the infrastructure so that whether it's preventing, chronic diseases or occupational accidents down the road or the next pandemic, God forbid, that comes our way, we'll already have those relationships developed and those paths will be worn so we aren't facing the same inequities and, having to reinvent the wheel all over again.
I think that was a really good description of how we can break through some of that. So thank you. And you did mention contact tracing in your answer. That was the subject of the last live webinar we did, which is archived and available on our YouTube channel. But there was one question that was asked during that webinar that we didn't have a chance to get to. So I wanted to throw it at Anne-Marie. Anne-Marie, the question was, what level of testing is being done in construction, and do we have any data about levels of virus spread among construction workers and workplaces, and has there been pushback from the industry regarding testing?
So, Chris, data is really hard to get with regard to these specific questions, and occupational data has been more challenging than others because the testing data is at the community level. It's being used, it's being collected at the hospital level and public health centers. We've tried to see if we can look at occupational levels so that we can know how much is affecting construction versus other industries, and we have been unsuccessful. We are actively collecting that data now, and so I'll have the answer in the future. Unfortunately, I don't have the answer with regard to how construction compares to other industries. However, I am running a very small study here in St. Louis with a few of the contractors who are, obliging me by sharing their cases in real time, and we've been doing this since the end of March. And what I can tell you, and I'm just looking at the data now, is that the trends for number of cases for these construction workers parallels the trends in our community. So the good news is it does not seem to have higher rates than what we would see in our community. And in fact, most of the cases that we know are coming from the community onto the work site. In fact, we've been tracing individuals once they have been identified as being symptomatic, any individuals that were exposed to them, those individuals have been quarantined, and then we've been looking to see if those exposed individuals eventually develop disease. And to date, this very, very small sample, we have seen no transmissions on our construction sites. I have to say that these contractors are, I think, doing a great job of implementing. They each have a COVID plan. They're implementing those plans, trying to maintain all of the goals that we've all laid out. So, I think contact tracing is a hard thing to do. It's falling under incident investigation for contractors, as it should, and it is confusing given this seemingly changing policies that are coming out of CDC, although I think CDC is doing the best they can with the knowledge that is known at the time. I hope that answers that question.
Yeah, thanks, Anne-Marie. I think there was a few questions related to what we know about the rates in construction, and the truth is we don't know because it's very, very difficult to track in real time, and we just simply don't have data as to industry and occupation of the infections. We do have data as to ethnicity and race, and that's why we're concerned about minority workers and Hispanic workers, but we don't necessarily have the same information related to industry and occupation. I just wanted to echo that.
Yep.
So I was going to, thank you for answering that question. I wanted to keep going just for a couple more minutes because we still have a lot of people on the line and get to a couple of other questions. And one question came in regarding the size of COVID-19 virus versus the N95 walls. And Christina, I was going to throw that at you. You know, the virus is really small. How do we know it's going to get trapped in an N95 filter?
All right. Can you hear me now?
Yeah.
Okay. Great. Yeah, sure. I'd be happy to take that question. So an N95 is a type of respirator that removes particles from the air that are being breathed in through it. And these respirators, they're called N95s because they filter out at least 95% of very small particles, around 0.3 microns at the minimum, of course. So they're capable of filtering out all types of particles, including most bacteria and viruses. And it's my understanding that the coronavirus particles, they actually travel within respiratory droplets, which are much bigger than the 3 micron range. So N95s would be good at capturing the particles. And there are some studies that have shown that as well. And so even the cloth face coverings can capture those respiratory droplets, of course not at the 95% efficiency rate, but they still do capture a lot, and that's why we're all encouraged and in some cases mandated to wear those cloth face coverings to reduce the spread.
Great, thank you. And there were a couple of questions that came in through the chat or through the Q&A I wanted just to throw out there. I'm not sure if someone can answer this question, but the question is, are there any medical exceptions for workers to not wear masks on a job site? Is there anybody who'd like to respond to that question? I would just give my opinion as an industrial hygienist and someone who knows OSHA regulations. There are limitations on respiratory protection, that the worker has to be medically evaluated before they are assigned a respirator on the job. Cloth face coverings are not respirators, so that rule wouldn't necessarily apply to them. But I could see a situation where an individual's physician would recommend against it, knowing that physicians tend to be very cautious. So I think that there's not one universal answer to that. There's not a guidance or a rule written down anywhere that talks about cloth face coverings. But there is guidance within the respiratory protection standard if you are assigning and requiring someone to wear a respirator on the job. So I would refer folks to that OSHA regulation if you're thinking about respirators with this question. The other question that's come in is about channels of communication, and it was specifically in response to something that Carl mentioned. How to reach this target audience of people at disproportionate risk. How do we do it? Do we do it through mainstream media radio, or do we do it through social media? And have there been studies about effectiveness of reaching different target audiences? I don't know if, Carl, you'd like to respond, or perhaps Mike has some understanding of this, but this is being sprung on both of you.
I can give just a little bit of what we're doing at the contractor level, and that was a great question about expanding on the channel opportunity there. We have some of our contractors, they're larger general contractors. They're using their social media, their outreach, whatever, Twitter, Tweeter, everything what the folks are utilizing out there. You can tell I'm a little bit older, but they're using as many channels as possibly get there. Some other things that we're utilizing, too, is going through the churches, sharing information at churches. That's a trusted ally. That's where many people go with their families. So sharing information through that, sharing information with our distribution channels, our supply houses, the Grangers, the folks like that, all the way down to the smaller local folks in a small town in Oregon or in Washington or anywhere in the country, trying to get information through them to help that out. But, the issue that we don't know is it truly having an impact? We hear that people are seeing it there, but statistically I couldn't say if it's been truly successful or not. But we think if one person gets it, it's better than none. So hopefully I answered that a little bit like you wanted.
Yeah, thanks.
Yeah.
Mike, did you have anything to add?
Yeah, I was going to add, I think, one, I agree with the social media. I think there are more folks on cell phones than we might think, particularly in the immigrant community. I also am a big proponent of things like YouTube videos or non-written forms of communication via social media. I think is a very effective way, especially when you're moving beyond languages, major languages like Spanish, but into more indigenous or pre-Columbian languages that are more spoken than written. The other thing we've done is we just put a paper together on a study we did on disseminating, general occupational safety and health information through the Mexican consulates. There are something like 49 consulates across the United States, and they have a health promotion program built into the waiting rooms there. And they see roughly, I think, 2 million people a year. And so we just did a series of posters, videos, and brochures getting some basic information out, and then had a kind of exit interviews on the way out for folks. And even the posters, which were the least effective, were seen by roughly about 50% of the respondents. And so even minimal efforts like putting a poster together or a brochure that's sitting on a table can still reach a significant number of people who said that they saw it and interacted with it at some level. So I think, again, finding those key community groups that already have built the trust with the community is a great, because I think over like 80 to 90% of the folks who actually saw the materials said they trusted the information and were thinking about doing something with it. So I think, again, it's all about the partnerships and finding those trusted institutions that already exist, while we try and build long-term trust for ourselves in those communities.
And thanks, Mike. That actually answers another question that came in on this similar topic. But if you have anything published that you can share with Jessica so she can send it out as a follow-up with her follow-up email, that would be good. And we do have a study at CPWR that we funded several years ago that we'll try to throw in there too about novel ways to communicate with different minority populations in construction. Well, one question that comes in every webinar we have is about the exhalation valve on a respirator, and is there a risk there, or could it be transmitting the disease? Well, I think that actually is under study right now. There's arguments on different sides of it. If you have people in valved respirators, they should all be in respirators, so they should be protected if they're in respirators versus cloth masks. That's my view. However, there is there are people who believe that the tortuous path that air does travel through an exhalation valve is at least as torturous as it travels around poor-fitting cloth face masks. So I think once we hear the results of that study, we'll definitely be sharing them when we know more information about that question. With that, I wanted just to wrap up and see if Christina or Mike could respond to a couple of questions regarding face shields. One question was, can an employee wear a face shield as a substitute for cloth covering if they have a medical condition preventing them from wearing a mask? And also, a similar question, can trade workers wear face shields instead of wearing a mask during hot weather? I don't know if NIOSH or CDC has issued an opinion on that, but in case Christina or Mike do, I was wondering if you could respond.
Hey,
and hearing, oh, go ahead. Well, I was going to give you an out. If CDC hasn't put anything out on this yet, I think that might be the answer, but please continue if you do have information.
No, I was just going to say I'm an anthropologist, so that's beyond my scope.
Okay.
I have a sister who is a healthcare worker at a foster home, and I was looking up some of the guidance for her because they were having her wear basically an N95 with a cloth face covering over it, and the CDC guidance is to wear the shield in addition to the N95, and that really helps with if you do have any issues that might prevent you or limit your use of an N95, a face shield will really help because you don't have to cover it with a surgical mask or the cloth face covering. So that's kind of the extent to my knowledge, but I can do a little digging and see if I can find out some resources for face shields. It's my understanding that because the air can easily escape from the sides, that they're not at the top of the recommendation list, but if you do have to wear them, there are some guidance on ensuring that they go below your chin and they go to the sides of your face as well. So let me try to look something up and get some information for you guys on that, but that's as far as off the top of my head.
Thank you, Christina. And also, Jessica has posted to all participants that one of our attendees has shared a CDC webpage that may provide guidance on conditions that can affect someone's ability to wear face coverings. Thank you, whoever shared that with Jessica. She shared that link with everyone. With that, I am going to wrap up this webinar. I appreciate folks who have stayed on the line. We still have a lot of you on the line, so I wanted to extend it beyond 3 o'clock Eastern. But please stay tuned. We'll be announcing our next webinar in this series as soon as we have identified the speakers for it and the date. So really appreciate it, and thank you, speakers, very much for sharing your insights, and thank everyone who joined us today. Have a great afternoon.